The modified walking bleach, where the pulp chamber remains open, gives you a bunch of advantages. Basically, the patient does it themselves at home, so there's less back and forth for them. So it's a lot more convenient for them. There's less chair time for you, so you get the same outcome in a more profitable manner. We make night guards for the patients. Now, usually most patients, after they've whitened the one discolored tooth, want to whiten the rest of their teeth. So you already have a night guard to do that, so that's more cost-effective for them. And also, if you don't have to go in and out of the tooth all the time, typically in my hands, with a regular walking bleach approach, you need to re-enter the tooth probably 4 or 5 times. It's less destructive to the tooth. Because even if you're really careful, you always end up removing a little bit more enamel or dentine. What do we need? We need a healthy periodontium. We need a good quality root canal therapy. We confirm that by clinical examination of the patient, history of the patient, and radiography, plus or minus cone beam. And we need an effective coronal barrier seal. Why do we need a coronal barrier seal? This is a seal over the gutta perca. 2 reasons. Firstly, it seals the gutta perca. Secondly, it stops a problem called external invasive resorption. This is where the bleach and the bleaching products go from the pulp chamber via the dentinal tubules, hit the periodontium, and cause loss of dental hard tissue. So we need a coronal barrier seal to prevent external invasive resorption. Now, what do we do first of all? First thing to do is we need to do a chamber cleanup. So I use a water-aided particle abrasion using this bit of kit. This is from Velapex. The material I use for my particle abrasion is not alumina nowadays, it's bioglass. This is called silk. The reason why I use this, it's a softer particle, creates less damage to the tooth. It also gives you higher bond strengths because you're basically impregnating the dentine with calcium. Gives long-term bond stability, and the debris from the silk is quite needle-like, so it ruptures the cell walls, is more bactericidal. Now, where are we going to put the barrier? What shape should it be, and what's the ideal material? In terms of where the barrier is going, basically what we do is we bone sound mesial, distal, and mid-buccal, and then based on the bone sounding, we measure internal of the tooth using the incisal edge as a reference point, and we place a barrier which is 3 millimeters in section, 1 millimeter above bone level, and 2 millimeters below bone level. So it's 3 millimeters in section in total. And we verify that radiographically. So here we are with our coronal barrier seal. It's 1 millimeter above the bone, 2 millimeters below the bone.